All right. So I decided to go into the intersection of heart failure and pregnancy because, well, I'm interested in cardiology, and I was intrigued as to learn more about how heart conditions can affect a pregnancy and how certain risk factors can lead to a complicated pregnancy along the way. So I was going to start with some epidemiology first. So this is just some facts about heart failure. There's approximately 6.7 million Americans above the age of 20 that have been diagnosed with heart failure. The number is expected to rise to about 8.5 million by the year 2030. The lifetime risk of heart failure has increased to 24%. Approximately 1 in 4 persons will develop heart failure in their lifetime with the um, the trend that we're seeing so far. And specifically, when we're looking at gender differences, the global number of heart failure cases have increased, with more heart failure cases in women compared to men. And there are different risk factors associated with heart failure within the genders. For men or for women, diabetes, hypertension, and tobacco use have a stronger association. Okay. And so in terms of heart failure in pregnancy, heart failure actually is a leading cause of morbidity and mortality in pregnant women in the United States. And one of the things that I learned when researching this was peripartum cardiomyopathy, which is a diagnosis of exclusion. And it actually is the #1 cause of heart failure in pregnant women. And it's a weakening of the heart muscle, leading to reduced ejection fraction heart failure. And it typically is diagnosed in individuals without a prior diagnosis of heart disease. And it usually is diagnosed towards the end of pregnancy and a couple months following pregnancy. And besides PPCM, there are other differential diagnoses that can be included, such as Takotsubo cardiomyopathy, familial cardiomyopathy, hypertrophic, among others. And so these factors and these facts leads providers to assess different implications of how pregnancy can affect a woman, depending upon the risk factors they possess and the outcomes that can occur during a pregnancy and after pregnancy for the mother. So when I talk about risk factors, we're looking at two different classifications, the MWHO risk classification and the CAR-PREG-2 scores. So the MWHO risk classification is used to evaluate the risk of pregnancy by medical condition. So there are 4 classes. Class 1 shows that there's no detectable risk of maternal morbidity or mortality. Class 2 says there's a small risk. Class 3 shows a significant risk, and mothers will have to go through expert counseling and monitoring throughout the pregnancy, and the counseling will include risk factors and implications of what the pregnancy will look like for the mother and post-birth. And class 4 is extremely high mortality, morbidity, and risk of pregnancy may be too high to consider pregnancy. And then the CAR-PREG-2 scores are also used in conjunction to determine risks associated with pregnancy. And what I've noticed is that patients who do possess these different risk factors, along with the risk assessment with these 2 scores, you're going to go through a thorough physical, you're going to go through a thorough history of the patient, functional capacity assessment, as well as an echocardiogram, just to see what you're dealing with in terms of the patient, because every patient does have a different baseline and how they'll react to a pregnancy. Whenever the score is above a 4 for CAR-PREG and a class 5, then the patients are cautioned against pregnancy. As you can see along the WHO classification with class 4, I want to mention there is a previous peripartum cardiomyopathy is present with any residual impairment of left ventricular function. So this just shows that if you have had a pregnancy in the past and which has resulted in a diagnosis of peripartum cardiomyopathy, and you're still having residual impairment of your ventricular function, then it is classified as a class 4, and there is a 50.3% risk of maternal adverse cardiac effects, and you are typically advised against a second pregnancy, just because of the risk factors associated with that. And there are also many more cross implications, so I'm going to go into them real quick. But before I go into that, I want to talk more about peripartum cardiomyopathy because it is the most common cause of heart failure in pregnancy. And risk factors associated with that include preeclampsia, multiparity, multifetal gestation, older age, and those cardiovascular risk factors I mentioned in the previous slide. So typically it's defined as heart failure with a left ventricular systolic dysfunction, and its ejection fraction of less than 45%, typically towards the end of pregnancy or in the months following delivery. And from the data that I assessed, about 13% of women with PPCM experience a major event. And major events are classified as death, transplant, LVAD placement, or having persistent left ventricular ejection fraction of lower than 35% post-diagnosis. And no subjects with the baseline of left ventricular ejection fraction of less than 30% and left ventricular end diastolic diameter of greater than 6 centimeters recovered by 1 year postpartum. But if your numbers were greater than 30% and your diameter, your end diastolic diameter was less than 6%, then 91% of patients did recover. So typically the main problem with peripartum cardiomyopathy is after the diagnosis, and if you have that persistent left ventricular ejection fraction that's less than 35%, that's where typically the complications come from, and you would have to be put on medication for that heart failure. So women with, like I said, women with prior PPCM are at high risk of adverse events in subsequent pregnancies. Some patients actually have PPCM and they don't end up having any persistent left ventricular ejection fraction decrease following their diagnosis, which is a good outcome in comparison to patients who do have the residual left ventricular dysfunction. And 44% of those patients will end up developing increased heart failure symptoms if they have a subsequent pregnancy. And typically the treatment for the diagnosis depends upon if it's diagnosed during the pregnancy or versus after. And if it's diagnosed during, you want to not go towards ACE inhibitors. Those are typically given following delivery, but physicians will look at beta blockers, loop diuretics, digoxin, and nitrates. And given the hypercoagulability of pregnancy, anticoagulation medication can be looked upon as well, excluding warfarin due to its adverse events. And the paper that I was reading actually looked into bromocriptine, and it has been studied, but it's not considered a standard part of care because of its continued studies being done on it. It's a dopamine antagonist, so it's not approved or part of standard care yet, but it is a drug that is being studied for this condition. And a pre-existing cardiomyopathy is another factor you want to take into account if a patient is pregnant. So women that have undiagnosed or asymptomatic left ventricular dysfunction can also be at risk during pregnancy. And the pregnancy has a high hemodynamic stress element to it. So patients typically decompensate during the second trimester due to the progressive expansion of blood volume. And this is in comparison to PPCM, which typically happens at the end of pregnancy or after. And typically the side effects with asymptomatic or undiagnosed cardiomyopathy during pregnancy, usually there's ventricular atriarrhythmias, sudden death of the infant, heart failure, and premature delivery. And the severity of the complications like PPCM typically depend upon the patient and genetic factors and the extent of the cardiomyopathy. And same as the previous slide, hypertrophic cardiomyopathy is the most common genetic cardiomyopathy. And like I said earlier, pregnancy has a high demand hemodynamically, and your left ventricular contractibility increases, which causes normally a controlled HCM to have worsening symptoms due to the increased obstructive physiology and its reduced diastolic filling time. And typically the medication regimen is reviewed carefully to minimize fetal effects, as well as control the patient's condition. And just one more thing that I want to talk about that I found pretty interesting was patients with LVAD wires. Pregnancy is not recommended for patients with LVAD wires, and a contraceptive should be sought for all women of childbearing potential due to the significant risks behind pregnancy with LVADs. And these are some of the complications that I found interesting to look into. The complications include bleeding secondary to von Willebrand disease, uterine impingement, risk of right ventricular failure upon delivery, increased risk of device thrombosis, and this is especially true just because of the hypercoagulability state of pregnancy, and significant increase in cardiac output, leading to the need to adjust the LVAD speed for greater accommodation. And this just shows that the greater cardiac output will end up putting the heart at a bigger stress level than it normally is, its baseline, and causing the LVAD to have to do more work, and it's just not the best idea to go through pregnancy while on LVAD wires. And these are just some the studies that I looked at and was reviewing today, and that's all that I had.